Welcome back to part 3 of pharmacotherapy of Parkinson's disease. So far, we'll go back to the outline. So far we've done what is Parkinson's disease, what is the cause of Parkinson's disease, what are the signs and symptoms, as well as we've gone over some simple treatments and the research and effect size. And for the research articles, we've gone through therapies in Parkinson's disease, differential effects of dopaminergic medications on the basic motor performance and executive functions of Parkinson's disease, and right now we're at the effects of monoamine oxidase type B inhibitors on motor and non-motor symptoms in Parkinson's disease, a systematic comparison of razagiline and selegiline. So, in this article, this study compares the effects of razagiline and selegiline with Parkinson's disease patients to determine the efficacy of both the motor and non-motor, such as cognitive therapeutic effects. Particularly, they compared the two as a monotherapy in early Parkinson's disease and as adjunctive therapy with levodopa in advanced Parkinson's disease, with a comparative placebo. Their conclusions for early Parkinson's disease are that both drugs improve motor function and overall Parkinsonian disabilities. In advanced Parkinson's disease patients, razagiline appeared to be more effective with motor fluctuations. And for non-motor symptoms, however, selegiline did not have an effect on cognition, whereas razagiline improved some attention and executive functioning. Razagiline also was shown to have positive effects on mental activity and fatigue, but data is limiting to provide any solid evidence for non-motor symptoms. For razagiline, they found the UPDRS ADL score, which is Activities Daily Living, a score ranging from approximately 0.8 to 1, which means that between 47.4 to 62.2% of the data did not overlap with the control group and was therefore not attributed to chance effects. Also, for the UPDRS motor scores, they range from approximately 1.7 to 2.7, which means that greater than 75.4% of the scores did not overlap with the control group, and therefore the effects can be attributed to the effect of the drug. Overall, the UPDRS ranged from about 3 to 4.2, which means there is very little, if any, overlap between the control and the experimental group, meaning that the drug had a significant effect. As for the selegiline, the UPDRS ADL score ranged from about 0.5 to 1, therefore about 33% to 55.4% of the data overlaps with the control, meaning there was a medium effect. As for the UPDRS motor score ranged from 0.7 to 1.7, which means that 43% to 75% of the experimental data is not overlapping with the control data. So overall, the UPDRS results from selegiline range from 1.96 to 2.7, which means greater than 79.4% of the experimental data did not overlap with the control, and therefore the drug had a significant effect. Okay, the next research article is Razagiline, a review of its use in the treatment of idiopathic Parkinson's disease. This paper reviews Razagiline's pharmacological effects, therapeutic efficacy, and tolerability of the drug as monotherapy or as adjunctive therapy to levodopa in PD patients. Although pharmacological effects are useful for explaining the mechanism of action, the information of interest in this article was the therapeutic efficacy. So, in the first portion, they examine the effects of razagiline on slowing the progression of the disease. They compared two studies that consisted of two large, randomized, double-blind, placebo-controlled multinational studies. By large, I mean they had greater than 400 participants per study. One thing to note is that they used standardized scales like the Unified Parkinson's Disease Rating Scale, the Hoehn and Yahr scale, and the Activities of Daily Living scale as a measure of the effect. They found that at 1 milligram per day had a higher UPDR score in the two studies, which means that the progression of the disease was slowing significantly. But at a higher dosages, such as 2 milligrams per day, the effect is not increased, so there is a limit there. In the second portion, they examined the combined effects of razagiline and levodopa. The two studies included large, double-blind, multinational studies that examined the efficacy of adjunctive therapy. And once again, they used about 450 per study. So at 0.05 milligrams a day or 1.0 milligrams a day, the dosages significantly improved the clinical global impression score, which measures symptom severity. The UPDRS Activities of Daily Living subscale score, and the UPDRS Motor subscale score compared to the placebo group. So it increased or improved those as well. So one critique that I have is in regards to the second portion, in which they used a post hoc analysis of the data in the two studies. This means that they gathered the data and then drew a conclusion from the data. This can be problematic as you can be selective as to what the data actually tells. So the next study is pharmacological studies with endogenous enhancer substances such as beta-phenylethylamine and tryptophamine and their synthetic derivatives. So this paper reviews the effects of beta-phenylethylamine and tryptophamine and their synthetic derivatives such as salicyline and BPAP. Now, by enhancer effect is referring to the release of neurotransmitters such as norepinephrine, serotonin, and dopamine. The data showed that tryptamine has more of effect as an enhancer than PEA, which is the phenylethylamine. For serotonin, whereas PEA is better enhancer for norepinephrine than tryptamine. Salicyline has been shown to be a good enhancer for the release of dopamine, and they found that the enhancer effects of the salicyline are supported by other studies. But there is also another synthetic enhancer, which is BPA, that can surpass the therapeutic effects of salicyline in treating Parkinson's disease, depression, or Alzheimer's disease. BPAP is an even better enhancer for both dopamine, norepinephrine, and serotonin. But as with the other drugs, BPAP has ideal concentrations in which it is effective.